You know that feeling, like a sudden thump in your chest, or maybe your heart feels like it's racing for no reason.
Oh, yeah, that fluttery skipped beat sensation. It can be pretty unnerving.
Totally. And today, we're diving into what's behind those feelings, heart arrhythmias.
That's right. Basically, the heart's electrical system going a bit off script. And we actually got some fantastic material from a listener to guide us.
Yeah, and this isn't your standard dry medical text. The document, this arrhythmia review, it literally starts, "Hi all." It even has a little grin in there.
Huh. Yeah, very approachable. You can tell it was meant for, actual people trying to learn this stuff quickly in a busy setting, like a medical ICU orientation.
Exactly. So our mission today is to kind of pull out the core concepts about arrhythmias from this review, make it clear, make it engaging, but without getting totally lost in the weeds of complex medical jargon.
Think of it as the highlights reel, a shortcut to getting your head around a complicated topic.
Okay, so where do we start? The basics, right? The heart's own pacemakers.
Right. The source lays it out nicely. You've got the SA node, sinoatrial node, up high in the right atrium. That's the main boss, basically. It sends out the first electrical signal.
And that signal makes the atria, the top chambers, contract.
Yep. And that contraction is what we see as the P wave on an ECG tracing.
Got it. P wave equals atrial squeeze. Then what?
Then the signal travels down to the AV node, atrioventricular node. It sits right between the atria and the ventricles.
And that's like a gatekeeper.
Kind of, yeah.
Yeah.
It holds the signal for just a fraction of a second, lets the atria finish contracting, and gives the ventricles time to fill up with blood.
Ah, okay. That lets the signal through.
Then it passes it down to the ventricles, the bottom chambers, causing them to contract and pump blood out. And that big ventricular contraction, that's your QRS complex on the ECG.
So P wave, then a little pause, the PR interval,
Yeah.
then the QRS.
Exactly. And after the QRS, you get the T wave, which is the ventricles resetting, repolarizing. And then there's the QT interval and that flat line in between beats, the isoelectric line.
And the source mentions that if any of these parts are missing or look weird, it tells you something's up.
Definitely. Like no P wave, maybe the atria aren't doing their coordinated squeeze, long PR interval, could be a delay getting the signal through that AV node.
And obviously no QRS is bad news. No ventricular pump.
Very bad news. And even changes in the T wave, the review points out, can hint at problems with the ventricles resetting or even, signal ischemia or a heart attack if they're elevated or depressed from that baseline.
Okay, makes sense. Now, why do monitors often default to showing lead 2? I remember reading that in the review.
Yeah, that's a good point. Lead 2 gives a really good view of the heart's normal electrical pathway. Imagine the negative electrode is up near the right collarbone, and the positive one is down towards the left lower ribs near the heart's apex.
So the electricity normally flows from negative towards positive.
In a normal beat starting from the SA node, yes. And because the main flow of electricity is heading towards that positive electrode in lead 2, you get that characteristic upward spike for the QRS.
Ah. So if a beat starts somewhere else, like in the ventricle?
Right, like a PVC, a premature ventricular contraction. The source notes these often show up as a downward deflection in lead 2.
Because the signal is starting low and spreading upwards, away from that positive electrode.
Exactly. It's going against the usual flow, so the waveform flips. It's a neat diagnostic clue sometimes.
Cool. Okay, so that's the normal setup. But why do things go wrong? What actually causes these arrhythmias?
Well, the review breaks it down pretty neatly into acute causes and chronic ones.
Okay, acute stuff first.
Acute is often about the heart being suddenly stressed or damaged. Think lack of blood flow ischemia or lack of oxygen hypoxia.
Like if someone's having breathing problems.
Exactly. Or an actual heart attack, an MI, myocardial infarction. Even electrolyte imbalances like low potassium or magnesium can really mess with the heart's electrical stability.
So things that need fixing now.
Right. And the review connects these to immediate treatments. Like, remember the LMNOP thing for treating acute heart failure symptoms? Lasix, morphine, nitrates, oxygen, position. It's all about tackling the underlying stress quickly. Or giving clot busters for an MI to restore blood flow.
Fix the cause, hopefully fix the rhythm.
Often, yes. But then there are the chronic issues. The review talks a lot about the heart chambers actually stretching out over time.
Like physically getting bigger.
Yeah, from being under strain for a long time. It uses the example of cor pulmonale. That's when lung problems, like severe COPD maybe, cause high pressure in the pulmonary artery.
So the right side of the heart has to work much harder to pump blood into the lungs.
Precisely. And over time, that extra work stretches out the right ventricle and the right atrium. The source highlights the stretching is a really common reason people develop atrial fibrillation.
Ah, so that's why you see AFib a lot in smokers or people with COPD.
Very common connection. And also, interestingly, the review mentions liver patients too, sometimes due to pressure changes. It even gives a specific case of a patient with a liver tumor developing atrial flutter because of that pressure backing up on the right side.
Wow. And the review mentioned something about the heart liking to be small and tight.
Yeah, basically saying that when the muscle stretches and gets kind of boggy, the electrical signals just don't travel as smoothly or reliably. It makes misfires more likely.
And that stretching isn't just a right-sided problem.
Nope. Left-sided stretching happens too, especially in congestive heart failure where the heart's pumping function, the ejection fraction, is low. That can lead to ventricular issues, extra beats, or ectopi originating from the stretched left ventricle.
Which brings up that question the review posed.
Mm.
That funny line about, is Mr. Yakowitz allowed to have triplets?
Huh? Yeah, referring to 3 PVCs in a row. It's a good way to think about it. Some level of ectopi might be chronic and tolerated for a particular patient, but a sudden increase or certain patterns like triplets, that might signal something new and concerning is happening.
Okay, so some arrhythmias are tolerated, some are emergencies. What's the crucial difference? What really makes an arrhythmia bad?
According to this review, the absolute bottom line is, can the patient maintain their blood pressure? Are they perfusing their organs?
So it's less about how chaotic the ECG looks and more about how the patient is.
Exactly. Take atrial fibrillation again. On the monitor, the atrial activity looks like total chaos, no clear P waves, just that fibrillation, that quiver. The source calls it a bag of worms on top.
Vivid.
It is. But if the ventricles are still responding at a reasonable rate, say, the example given was around 70 beats per minute, they might still have enough time to fill between beats.
So even with the chaotic atria, if the ventricular rate is controlled, the pump might still be working okay.
It might be sufficient to maintain blood pressure, yeah. The patient might feel it, but they aren't necessarily crashing.
Which really hammers home the importance of that ventricular rate.
Absolutely. Too fast. Like if the ventricles try to keep up with chaotic atrial signals at 200 beats per minute, there's just no time to fill. Cardiac output plummets, blood pressure drops.
And too slow is also a problem, obviously. Not enough beats per minute.
Right. So the review gives that general guideline. A ventricular rate between 60 and 100 is often the sweet spot, the okay zone, even in rhythms like AFib.
Okay, let's dig into that term ectopi. The source defined it really clearly.
Yeah, it just means something happening where it shouldn't, like an ectopic pregnancy outside the uterus or ectopic brain activity causing a seizure.
So in the heart, it's a beat starting somewhere other than the SA node.
Exactly. And the interesting thing the review reminds us is that pretty much all heart muscle tissue has this property called automaticity.
Meaning any part of the heart could potentially start a beat, like backup generators.
Kind of, yeah. Every cell has the latent ability to act as a pacemaker. But normally, the SA node is the fastest, so it sets the pace for everyone else.
The heart listens to whoever's shouting loudest or fastest.
That's a great way to put it. If some other spot, maybe in the atria or down in the ventricles, gets irritable or damaged and starts firing faster than the SA node,
It takes over.
it can capture the heart rhythm, yeah. That's where your PACs, premature atrial contractions, or PVCs, premature ventricular contractions, come from. An ectopic focus firing early.
And if that ectopic spot keeps firing rapidly,
Then you can get into sustained arrhythmias. A run of rapid beats from the atria could become SVT or rapid AFib. A run from the ventricles is ventricular tachycardia or VT.
and the normal rhythm can't cut back in until that faster ectopic rhythm stops or is treated.
Generally, no. The faster rhythm dominates. And like we said, if that fast rhythm is too fast for the heart to fill properly, that's when it gets dangerous.
Okay, let's walk through some of the specific rhythms the review covers, starting with the supraventricular ones. That means anything starting above the ventricles, right?
Yeah.
Atria or AV node.
Correct. Atrial rhythms and junctional AV nodal rhythms fall under this category. And the baseline, the gold standard, is normal sinus rhythm.
P wave before every QRS, rate 60 to 100. Everything working as expected.
Textbook. Then the review mentions sinus arrhythmia.
The one that changes with breathing.
Yeah, the heart rate speeds up a little when you breathe in, slows down when you breathe out. Totally normal, benign variation.
Okay. Then sinus bradycardia. Slow heart rate, less than 60.
Right, but still originating from the SA node, so you still have those P waves.
Yeah.
Can be normal, like in athletes, or during sleep, or if someone's on beta blockers.
But it can be a problem?
It can. The review flags it especially with an inferior MI, where it might need treatment with atropine. or if the SA node itself is diseased.
And the opposite, sinus tachycardia, rate over 100, but still P waves present.
Yep. And usually this is the heart responding to something else. Fever, anxiety, dehydration, pain, low blood volume.
So don't just jump to slow it down.
Generally, no. The source advises treating the underlying cause first. The exception might be in an acute MI, where that fast rate increases oxygen demand on an already stressed heart. Then you might use beta blockers cautiously.
Okay. What about paroxysmal atrial tachycardia?
Right, paroxysmal meaning it comes in sudden bursts. It's a rapid rhythm starting in the atria, maybe 150 to 250 BPM. Can be short-lived, maybe not need treatment if it stops on its own.
But if it keeps going?
It becomes a sustained SVT, supraventricular tachycardia, and could compromise blood pressure.
Got it. Then packs premature atrial contractions, those early beats from the atria.
Uh-huh. Coming from a spot other than the SA node, so the P wave might look a bit different, usually benign if they're just occasional.
But if they happen a lot?
The review suggests frequent packs can sometimes be a warning sign, maybe leading to AFib down the road. And there's atrial gemini, where every other beat is a pack. Same potential concern.
Okay. Atrial flutter. That sounds like AFib, but different.
It is different. In Flutter, the atria are beating very fast, maybe 300 times a minute, but it's usually an organized, rapid circuit. Think of it like race cars going around a track very fast in the atria.
But the ventricles don't go that fast.
Usually not, thankfully. The AV node blocks some of those signals, so you might get, say, a 2.1 block, meaning 300 atrial beats leads to a 150 ventricular rate, or maybe a 3.1 or 4.1 block, leading to slower ventricular rates like 100 or 75.
Is 150 okay?
150 can be problematic, potentially lowering blood pressure. A slower rate like 100 might be tolerated better. The review mentions older maneuvers like carotid sinus massage to try and slow the AV node, but now we mostly use drugs like calcium channel blockers, beta blockers, or sometimes adenosine. Flutter often converts to AFib eventually.
Which brings us back to AFib, the bag of worms.
Yep. Totally chaotic atrial activity, irregular ventricular response. Rate control is absolutely key, aiming for that 60-100 range.
And the big danger is clots.
Huge danger. Those poorly contracting atria are prime spots for clots to form. If the heart then suddenly converts back to a normal rhythm, those clots can get ejected. Stroke risk is high.
So anticoagulation is critical. Heparin, warfarin.
Essential for most patients with AFib, especially if it's new or comes and goes. Paroxysmal.
Okay. What else in the supraventricular world? WIP and MAT.
Wandering atrial pacemaker, WAP, and multifocal atrial tachycardia, MAT. These are similar. The pacemaker site keeps shifting around the atria, so the P waves look different from beat to beat.
And the difference is just the heart rate.
Pretty much. WP is when the rate is under 100, MAT is when it's over 100, often seen in patients with lung disease.
All right. How about beats starting from the AV node, the junction?
You can have premature junctional or nodal beats. They're early, like PACs, but because they start in the junction, there's usually no P wave before the QRS, which typically looks normal, generally benign.
And the opposite, late beats from the junction.
Those are junctional escape beats. The SA node fails to fire on time, so the AV junction steps in as a backup. Again, no P wave, normal QRS, but it comes late. It's a safety mechanism.
The review mentioned escape capture bigeminy.
Yeah, that's an interesting pattern where you get a normal sinus beat, then a junctional escape beat, then sinus, then escape. It suggests the SA node is struggling and might be a sign of impending heart block.
And if the junction just takes over completely?
That's a junctional rhythm, no P waves, normal QRS complexes, and the rate is typically the intrinsic rate of the AV junction, which is around 40 to 60 beats per minute.
The review had a note here. Junctional. Dude.
Yeah, probably just emphasizing that intrinsic rate, 40-60. If it goes faster, say 60 to 100, but still no P waves and normal QRS, that's an accelerated junctional rhythm.
He's that guy.
The rate itself might be okay, but you lose that coordinated atrial contraction, the atrial kick, which normally adds about 25% to cardiac output. So perfusion might be reduced.
Okay, last one in this group. AV dissociation.
Right. This means the atria and ventricles are beating completely independently. They're not talking to each other electrically.
How does that happen?
Two main ways described. One is complete heart block. The signal from the atria just can't get through the AV node at all. So the atria beat at their own rate, driven by the SA node, maybe 70 BPM, and the ventricles beat at their own much slower escape rate, maybe 30-40 BPM, originating somewhere below the block. You see P waves marching along completely unrelated to the slow, wide QRS complexes.
And the other way.
Is when there's an escape rhythm, maybe junctional or ventricular, that's actually faster than the sinus rate. So the ventricles are being driven by this faster escape focus, and the SA node is still firing, but its signals aren't getting through or are arriving when the ventricles are already busy. Again, P waves and QRS complexes are independent, often caused by ischemia or MI affecting the AV node.
Okay, that covers the supraventricular stuff. Now down into the ventricles themselves, ventricular arrhythmias.
Starting with PVC's premature ventricular contractions. Those early, wide, bizarre-looking beats.
Because the signal starts in the ventricle and spreads abnormally.
Exactly. Travels cell to cell through the muscle, not the fast conduction pathways. Context is key, as the review stresses. Are they new? Is the patient having chest pain? Check electrolytes, especially magnesium. Also, feel the pulse. A PVC might not generate a strong enough beat to be felt peripherally.
And the review defined different patterns.
Yeah, couplets are 2 PVCs together. Triplets are 3 in a row, which can also be called a run or salvo or non-sustained VT. Then there's bigeminy. Every other beat is a PVC. Trigeminy every third. Quadrigeminy every fourth.
And more than 3 in a row that stops on its own is non-sustained VT.
Correct. Always worth investigating the cause: ischemia, hypoxia, electrolyte problems, and always make sure it's not just artifact on the monitor.
Good point. But if it doesn't stop, if that run of PVCs keeps going.
That's ventricular tachycardia, or VT, a sustained run, potentially lethal.
What's the first thing the review says to do?
Stay calm, call for help immediately, check if the patient is responsive, and check for a pulse. That's critical.
Why? Does the treatment depend on the pulse?
Absolutely. Pulseless VT is treated exactly like ventricular fibrillation, immediate CPR, and unsynchronized defibrillation. Shock them.
Okay. What if they have a pulse?
If they have a pulse, check their blood pressure and perfusion. If they're unstable, very low BP, poor perfusion, then synchronized cardioversion might be needed, shocking them, but timed to their QRS. But they need to be unresponsive or sedated for that.
And if they have VT, have a pulse, and are awake.
Crucially, do not shock or thump them. Get help urgently, monitor them like a hawk because they could lose their pulse at any second. Treatment is usually with antiarrhythmic drugs. The review mentions amiodarone is generally preferred now over older drugs like lidocaine, citing the arrest trial.
Okay. Then there's ventricular fibrillation, VF.
That's just total electrical chaos in the ventricles. No organized activity, no pumping. Looks like squiggly lines on the monitor.
And the treatment.
Immediate unsynchronized defibrillation, shock as soon as possible, starting at 200 joules and escalating if needed. Then CPR, airway management, ACLS protocols. Time is critical.
The review also mentioned differentiating narrow versus wide complex tachycardias.
Yeah, it's a general rule of thumb. Narrow QRS usually means the rhythm started above the ventricles, supraventricular. Wide QRS usually means it started in the ventricles, like VT. But it's not foolproof, and the most important thing is always how the patient is doing. Are they perfusing?
Right. What about torsades de pointe?
Ah, that's a specific type of VT where the QRS complexes look like they're twisting around the baseline. It's polymorphic. The shape keeps changing.
It's linked to.
Often linked to a prolonged QT interval on the ECG, which can be caused by certain drugs. The review mentions Haldol as an example, or electrolyte problems. Treatment is often magnesium sulfate plus defibrillation if they're unstable.
Okay. An accelerated idioventricular rhythm, AIVR.
Right. Idioventricular means it's originating in the ventricles. Normally, the ventricle's own escape rhythm is very slow, like 20 or 40 BPM. AIVR is faster than that, maybe 60, 100 BPM, but still originating down low. Wide QRS, no preceding P waves.
Is it dangerous?
Often occurs when the sinus node slows down, maybe after reperfusion following an MI. If the rate is fast enough to maintain perfusion, it's usually transient and benign. But the review notes that irregular AIVR is considered dangerous, more like heart block.
And finally, the flat line. Asystole.
No electrical activity. Check leads, check the patient, start CPR, follow ACLS. Prognosis is very poor.
Phew. Okay, that's a lot of rhythms. The review also mentioned a couple of things it initially left out but wanted to include.
Right. SVT, supraventricular tachycardia, as a general category. We touched on PT, but SVT is the broader term for fast rhythms starting above the ventricles, usually narrow complex. Treatment really depends on stability. Stable, try vagal maneuvers, maybe adenosine. Unstable, synchronized cardioversion.
And the other one was WPW.
Wolff-Parkinson-White syndrome. That's a specific condition where people have an extra electrical pathway, an accessory pathway, bypassing the AV node.
Like a shortcut.
Exactly. And that shortcut can allow for very rapid reentry tachycardias, a type of SVT. On the ECG, you might see a short PR interval and a slurred upstroke on the QRS called a delta wave.
And certain drugs are bad for WPW.
Yes, drugs that slow the AV node, like verapamil or digoxin, can actually be dangerous in WPW with certain tachycardias because they might encourage conduction down the fast accessory pathway. Treatment might involve cardioversion or specific drugs like procainamide, and usually referral for specialized electrophysiology study.
Okay, so we really covered the gamut based on this listener's review.
We have, and I think the big takeaway, tying it all together, is that you always have to connect the electrical picture, the ECG, with the mechanical function, the pumping action, and the patient's condition.
Absolutely. The ECG tells part of the story, but the patient tells the rest. As the source kept emphasizing, that clinical context is just everything.
Yeah, this review did a great job of laying out the common arrhythmias, why they happen, and what makes them significant, providing a really solid foundation.
It really did.
Yeah.
It's been fascinating to break down this complex topic using such an accessible, practical source.
So maybe a final thought for you, the listener, to chew on. While learning to read these squiggles on the screen, these ECGs, is super important. Never lose sight of the person attached to the monitor. Is their heart actually working effectively? That's always the most crucial question. The patient's perfusion and well-being ultimately decide if an arrhythmia is truly good or bad.
Well said. And if any specific rhythm or treatment we discussed sparked your interest, definitely take the time to explore it further. There's always more to learn.